Hi, everyone. Welcome to LDI's seminar, Do No Harm, Balancing Innovation and Regulation in Healthcare, AI. My name is Rachel Werner. I'm the Executive Director of Penn's Leonard Davis Institute of Health Economics. We have a lot of great things to talk about today, really interesting topics. I'm privileged today to be able to introduce a group of people with tremendous expertise on artificial intelligence and its uses in healthcare. Glenn Cohen is the James A. Atwood and Leslie Williams Professor of Law and Faculty Director of the Petrie Flom Center for Health Law Policy, Biotechnology, and Bioethics at Harvard University. Nigam Shah is a professor of medicine at Stanford University and is the chief data scientist for Stanford Healthcare. Rangita de Silva de Alves is the Associate Dean of International Affairs here at Penn's Carey Law School, where she also leads the Policy Lab on AI and Bias. Our moderator today is Ravi Parikh. He is an Assistant Professor of Medicine and Health Policy at Penn and is Director of the Human Algorithm Collaborative Lab. Ravi, with that, I will turn it over to you.
Thanks, Rachel, and thanks to all around 200 of you for joining. So just to start, I kind of liken the past 1 or 2 years of AI to when your child says its first words. You spend all this time reading to your infant or toddler, hoping that something will sink in. There's just so much excitement over when it's going to happen, but also, just what your kid is going to say. And then out of the blue, your kid utters their first word, usually like when you're doing the dishes. And after that, all the guardrails are off. You just can't stop your kid from talking. And all that kinetic energy, that hype, has now translated to something real. And as opposed to controlling it like you tried to, you're just sort of along for the ride. AI in healthcare, at least in my opinion, has sort of been like that. After a decade of hype, the pace of how AI has evolved from tree-based predictive models and simple image-based classifiers to now generative text for clinical notes and diagnostic algorithms that rival the performance of a radiologist or a pathologist. It's all that transformed potential that has made us realize that AI has the potential to save lives and transform the practice of medicine. But without guardrails, there's also a lot of thinking that AI can disrupt care in harmful and inequitable ways. And that's what today's panel is going to be about. Less about technical innovations in AI and methodology, and more about the implementation of AI, particularly as it relates to policy, liability, and bias. We're going to focus specifically on AI that touches patients and clinicians, things like clinical or patient decision support, because that's what decision makers in government and health systems are grappling with. Questions about how to improve patient care, protect privacy, and reduce racial bias, all while avoiding unintentional errors. And we're hoping that this hour with this excellent set of experts can help us make sense of where we are with AI in healthcare and where we're going to be headed in the next decade. So with that, Nigam, I'll give you the first question. Can you start us off just by briefly describing 1 or 2 success stories of AI in Stanford, concrete examples about how AI is being deployed in your health system and touching clinicians and patients today?
So glad to be here. And before I launch into the concrete example, I want to sort of lay out a mental construct for our audience. Imagine the Mercedes-Benz logo, the 3-pointed star without the circle. And one point, the top point, let's say, is the model in question. The lower left, for example, let's say, is the policy that at what level of the model output will we take some action, along with our work capacity for taking said actions. And then the remaining sort of point of that star is the benefit and harm or cost trade-offs of the action that we're going to take. And I lay this out so that when I give the example, I can contextualize my comments. So the one that we've found the most impact and have gotten both patient feedback as well as sort of external awards is kind of a mundane thing of driving advanced care planning conversations using a predictive model's output. So it's nothing fancy, no deep neural net, no ChatGPT, no transformers. It's a simple random forest model that estimates the probability of someone passing away in the next 12 months. And we set the threshold fairly low. If the probability of that is above 25%, we flag the individual for having a goals of care or advanced care planning conversation. The majority of the value derives from our clinicians in the serious illness conversation program, creating a guide so that anyone who sees the alert is equipped to have that conversation with the patient or their relatives to initiate the conversation. And then we track that how often is it the case that we flag a patient and the subsequent follow-up conversation happens, who is taking the follow-up conversation. And then in areas where people are not following up, we sort of nudge them to ensure follow-up. And I'm very pleased to report that by having this system in place, we have raised the goal documentation rates around goals of care to over 15-20% when they were from what they were in the low single digits. Like if it's 1% and you go to 20%, that's a 20x, but that just sounds too fancy. So I say about 20%. And over the year and a half, about 6,700 patients have gotten goals of care documentation attributable to being flagged by this model. So that is something I'm quite proud of. Like, we don't get into showing the probabilities. We don't get into the nuances of the model. It's just a nudge saying, given our limited capacity, we can't follow up with everybody. Here's the 5 people we need to speak with today.
That's fantastic. Thanks, Nigam, for that detail. That gives us some clear examples to be thinking about as we talk about some of the more conceptual questions we'll tackle in this hour. So let's pivot to talking a little bit about your perspective on regulation. As we think about regulating AI for clinical or patient decision support, sort of like the same prognostic nudge that you described. You've described some potential paradigms from other technology in healthcare that can help us clarify what our goals and mechanisms for regulation ought to be. For example, regulating drugs, devices, or labs. Can you just briefly lay out that framework of goals and paths as if you were advising a federal policymaker?
Well, thank you. I'll try. I'm not too skilled at advising policymakers. So the way I think about the problem is that there's about 4 existing paradigms about how we approve technology or interventions in healthcare. The most commonest one that comes up in the context of AI is software as a medical device. That's the one that gets the most airtime, and there's like 570 or close to 600 approvals under that paradigm. But there are 3 other paradigms that we keep forgetting about. The second one I'll lay out is under the FDA, but under their drugs division, CDER, where we can test a digital intervention just in the manner we test drugs. And the first one that was approved under this paradigm was an app from Ginger.io to be prescribed as a intervention for managing depression. Then there is software practice management systems that fall under the ONC certification paradigm, and the certification criteria are set by NIST, and then an independent body can administer them, and then you can say, yes, my software is certified, and that's how EHRs are regulated. And then the last but not least is this notion of a laboratory developed test that falls under CLIA. And you could argue that an algorithm that is diagnosing somebody as having undiagnosed disease, saying, here's a patient that we believe has peripheral artery disease and we don't yet know, you could say that that's just a digital diagnostic and regulate that under the CLIA paradigm. So those are the 4 at our disposal, but we tend to overly focus on software as medical device.
Got it. That makes a lot of sense. Maybe just one sort of follow-up question, because you laid out a few different, at least government regulatory agencies that have dipped a toe in this area. How do you sort of think about trade-offs between regulation, over-regulation, and promoting innovation in the market, sort of letting market forces dictate what sort of makes it into patients' hands as opposed to how directive policymakers ought to be?
That is a tough one. I mean, it's being on the West Coast where we like freedom to experiment, but at the same time, you would not want experimenting with people's lives and health outcomes. And so I think the place where policy, where regulation should be injected is to be around what are the actions you're taking based on whatever technology that you're using. And we can have a risk-based approach that if the action you're taking is kind of irreversible, for example, you're taking out somebody's lung or amputating a limb, I would want a very high bar for accuracy, quality assurance, and testing. If the action is relatively low risk, like you're going to send somebody an email or send someone an Uber ride, I think we can afford a little bit of a lower bar or threshold for experimentation. And I think that risk-based approach, that's something also NIST is advocating for, is where we need to take our regulation towards. Because right now we kind of go for one size fits all, and that I think is not the right attitude. And the FDA has already started to move in that direction. That in the guidance that they've put out over the past year, like if it's high risk, there's no time for the doctor to sort of think about it. You're just going to immediately follow through. We want a very high bar in terms of regulatory clearance hurdles. So that's would be my recommendation, a risk-based approach.
Makes a lot of sense. Glenn, maybe I'll turn to you, and I'm wondering if you could sort of react a bit to Nigam's proposed framework here, and then layer on some concrete regulatory review initiatives that the FDA and or non-FDA regulatory bodies or other hospital systems have been thinking through as it comes to AI in clinical care.
Fantastic. So I'll start by saying I'm not a clinician. I'm trained as an ethicist and a lawyer. So I have 2 doses of clouds, often for the sunshine that other people bring to these conversations. So let me start with those clouds, which is to say this is an incredibly ethically and legally complicated space. And I'll just kind of give you a laundry list of the kinds of things that you'd want a regulator to worry about. And then I'll talk about who is worrying about this and the fragmentation of the regulatory scheme here. So the first thing I think to worry about is just whether where we're spending our money and where we're doing our emphasis really tracks where we can do the most good. And I often say that we're very good at taking excellent positions in the United States and making them even better. We're less good at democratizing the expertise we already have, given the gaps we have both in the US and across the world. And one of the biggest payoffs for AI, I think, is that democratization. And yet it's not always the case that the investment is tracked to that. So that's just an overall ethical concern. Then we say from building the model to deployment, here's just a bunch of things to worry about. Where does the data come from? Who gives permission for the data to be used? What kinds of privacy protections do we have people for risks of re-identification? How diverse and how representative is the data set? How accurate can we show that the AI is in terms of improving performance in the lab or on data? How accurate is it in the real world where we're dealing with the fact that there's a huge heterogeneity in the physician practice style, in resources at hospitals, in implementation and workload? How do we actually measure clinical efficacy? Because even if you have a great intervention that spots a lot more tumors, if it turns out because it spots them too late, you can't really do very much with that information, it looks quite different. How do you handle disclosure and informed consent to patients that an algorithm is being used? So to use Nigam's example, there's this great algorithm that is basically telling your physician that you're likely to pass away in the next X period of time. Is that the kind of thing that we should tell patients ahead of time? We're going to be running this, should we be asking for their permission? What does that look like? How do you handle errors and liability, especially when they're spread across different populations in different ways? And then even when you're incredibly successful and you've got something great, how do we make sure there's equitable access in terms of pricing, in terms of competition in these markets and the like? So that's a lot to worry about. And it turns out FDA at most is focused. FDA is an excellent agency. I think it's the leading agency compared to its peer regulators in the space. It's doing the best that it can. It's doing a pretty good job, but it's only looking at a tiny slice of that, largely to do with efficacy, accuracy, those kinds of issues. And even then, huge swaths of artificial intelligence in medicine are not reviewed by FDA, in part because Congress in the 21st Century Cures Act pared back a lot of decision support and a lot of other spaces. So the vast majority of medical AI that's being run on patients, FDA will never see. And instead, we're trusting the hospital systems and internal reviews to do this sort of stuff. Okay, one more dose of clouds and then I'll subside, which is just to say, all of this is tricky, but actually it gets worse. And here's why. when you build an algorithm, it would be really silly to build it on data and then deploy it out in the world where there's huge numbers of people and huge amounts of variation and tell it, don't learn anything new. Stay with what you learned when you came out of the door, right? We don't want algorithms like that. We want them to be able to understand context and to learn as they go, to be adaptive. Well, that's great. We definitely want that, but it means that the regulatory moment becomes much trickier now, because while you can do as much of this review ahead of time as you want to, there's the question of when do you know whether it's time for re-review? And here, this is a very difficult problem. FDA has a very interesting new program relating to predetermined change control plans that I think is a quite elegant, in theory, way to approach this problem, but how it's going to play out in practice, I think we're all taking a look at. But it's much bigger than FDA, and it's even much bigger than the government regulation, because we have to worry about how private actors are self-regulating in this space.
That's fantastic, Glenn. I appreciate how you layered a very complicated answer with some specific examples of what the FDA is actually doing. I want to pose something that's been brought up in the chat a couple of times, which is how you differentiate who's regulating. There's a particular question, around federal regulation versus state-based regulation. I'm wondering, just broad strokes, if this is even an issue that's robust enough to talk about yet, or whether, or if we are still figuring it out. What do you see of domains, whether it's states or other bodies of that sort of need to be built upon gaps that the FDA is missing?
Yeah, and some of this is by design in our US federalist system, as I was to say, it's not just that FDA is missing, is that it has limits on its powers. So 3 areas where I think states are pretty active and important. One is in privacy spaces. So for example, we have a number of states that have more robust privacy protections than the federal government. And while HIPAA doesn't let you can't go below the HIPAA level, you can actually supplement. And we see places like California doing this. The second is just a question of liability. So liability is basic common law of torts, medical malpractice. And we can talk more about this. One of the first questions I'm always asked as a lawyer in the room is to say, let's say I use one of these things and a patient gets care that causes an adverse event. Am I liable? Is the hospital system liable? How does that work? That's going to be almost entirely a matter of state law. And the third is just the regulation of the profession, whether it's informed consent or the question of what is the practice of medicine. So for example, when ChatGPT starts giving you answers to questions about medicine, at what point does it start acting like a physician and engaging in the practice of medicine versus acting like a computer program? And that's another area where states have a robust regulatory program.
Got it. Makes a lot of sense. There's a couple of questions in the chat around liability and disclosure, but if it's okay, I'm going to move to Rangita and then I'll come back to you, Glenn. So Rangita, maybe if we could bring you in here, as we've discussed, among the most prominent ethical issues raised by AI is its potential to bake in racial, ethnic, gender inequities, maybe inequities in subgroups that we're not even thinking about that exist in our world and our data. So I'm wondering if you can lay out the most common ways that this happens, how those develop, and how those who develop, deploy, and regulate algorithms might be able to prevent it. And in particular, if you can touch on how we can be proactive rather than reactive.
Thank you, Ravi, and thank you for convening this very important conversation, which I think is critical given that we are still at a Promethean moment of both great promise and great peril, as was stated earlier. And in Noam Chomsky's word, ML systems can both degrade our science as well as elevate it. So as you know, my own work examines bias in the real world as well as in AI from both a gender and an intersectional perspective, but also from a global South perspective and a human rights perspective. So as we know, data points are snapshots of the world we live in and reveal real world biases. And the large gender data gaps we see are partly due to those real world biases on gender, race, ethnicity, disability, and intersectionality. But no industry better illustrates this gap than the healthcare system. So I want to first traverse the terrain of 4 examples that I want to share with you, Ravi, because you asked for real world examples. For example, if ML systems are trained to recognize skin disease, such as melanoma, based on images from people with white skin, they might fail to recognize disease of underrepresented populations. Second, if algorithms use health costs as proxy for health needs, algorithms might falsely conclude that underrepresented minorities are healthier than their white counterparts. Thirdly, in an analysis of trends, to understand the developmental pipelines on the geographic distribution of clinical trials for AI and ML-enabled medical devices, scholars who have looked at clinical trials that are AI and ML enabled between 2010 and 2023 through the World Health Organization's registry platform found that countries with the most enrolled patients in clinical trials per 100,000 inhabitants were mainly countries in Asia and Europe. So it is important that more international trials should be encouraged, including the involvement of low and middle income countries, so as to improve both equality as well as to ensure that algorithms perform well across all populations. And then finally, bias is not an issue that is exclusive to artificial intelligence in medicine, but it has the most fatal consequences. So access to healthcare varies by factors such as gender, race, socioeconomic status. And what we see is that if AI algorithms learn from historical electronic recorded data, for example, testing for cardiac ischemia for women, and delaying potentially life-saving treatments might be fatal. So you asked for ways in which we can mitigate these biases, and we see a whole host of regulations. Glenn spoke about some of them. I want to very quickly look at the EU AI Act, which, as you know, was promulgated a few weeks ago in December of 2023, to be adopted in 2024, this year. So very quickly, some of the key elements of the EU AI Act, which provide helpful ideas for promulgating other AI-related legislation in different countries. First, the transparency. The transparency is written large in the AI Act. Second, the fact that instructions are to be accompanied with instructions on how to use AI, including the capabilities and the limitations of performance, including the intended purpose, level of accuracy, robustness, and specifications for the training, validation, and testing data. So those are the first two elements. And then thirdly, a public database as proposed in the draft legislation, which is a crucial step to improve trustworthiness by enabling a more robust evaluation of the benefits and risks of AI. So what I want to do next is to look very quickly on bias mitigation. And we see that that is two-pronged. First, how do we look at the ways in which data can be debiased? Now, we know that the relevant clinical data must first be collected and prepared for use in model development, and that these models involve selection and training of suitable mathematical algorithms to perform the intended task. So we have two levels. One is the ways in which the data needs to be debiased through representative data that is democratic, that represents populations, including persons with disabilities. And then secondly, how do we democratize and debias these mathematical algorithmic formulas? And that is still in its nascent stages. And one idea that has been presented is looking at this through the prism of almost looking at this from the way of affirmative action. So how can we use oversampling? How can subject that there is sampling bias, that, for example, if an ML-based system is trained to recognize skin disease, as I said, such as melanoma, based on images from people with white skin, how can we then bring adversarial debiasing or oversampling to achieve a better performance when applied to all populations? So including transparency, selected training data sets, mathematical approaches to debiasing, ML interpretability or explainability, and post-authorization monitoring are very important. And then finally, it is important for us to use a human rights analysis. These are human rights issues. They're not only regulatory issues, these are human rights issues. We have to bring a women's rights, disability rights, and rights of underrepresented minorities to address the disproportionate impact of these biases on minority populations. Thank you.
Thanks, Rangita. That I think set the stage really beautifully for how not only do we think about mitigation and detection of bias, but thinking a little bit about who we ought to be bringing to the table. And my next question is sort of on that vein. To what extent do you think engaging stakeholders is important in mitigating and preventing bias? A lot has been, so it said you talked a little bit about sampling methods and potential statistical methods to mitigate bias. But how upstream do we need to go with this? And in particular, how upstream do regulators need to be stipulating about who's actually at the table, giving input on what we predict and how we predict it, or whether the algorithm needs to be deployed in the first place?
That goes to the very heart of democratizing the process of developing these algorithms and in the collection of the data, and who is at the table and who is not at the table. And that is why we have to bring a structural approach to this, to really dig deep and to see what are the structural biases. And as I said earlier, the biases in the AI are not external, they're not artificial, they reflect the world that we live in, the biases and the stereotypes that are pervasive in our world. So how can AI be used in order to address those biases? As you said, first, do no harm. And on that premise, who are the stakeholders? As I said, are women represented as developers, as technologies, as leaders who set the agenda, who set the vision for AI companies? Women are underrepresented, and there's an asymmetry in the leadership among technologies, especially at the higher levels. So the women, persons with disabilities, so that we understand the ways in which this will have disproportionate impact on the most underrepresented groups in the development, but also a global South approach, Ravi. What is developed here in the global North is disseminated broadly in the global South, especially in the African continent and in the Asian region. And how does that impact those who are in the frontiers, those who are underrepresented, in the ways in which it can have a disproportionate impact and be harmful? So I love the way in which you frame these questions, frame the vision and the goals behind this conversation as first, do no harm. That should be the overarching understanding.
Niga, maybe you can build off of that a little bit.
Absolutely. So I'm glad Rangita brought up that point about the global South, and these issues predate AI. And I'm going to use a very simple example of the venerable Framingham equation, which became the pooled cohort equation, and as of a couple of days ago became a new equation called prevent. All the older versions were miscalibrated for women, men from Southeast Asia, and for people of African American origin. But we've never heard a headline that says those equations were racist or were somehow harmful. But the biases in them stemmed from the fact that the people whose data were collected to learn these regression kind equations were not representative of the whole planet. But their equations are still being used across the whole planet. Now, the exact same problem is going to happen in algorithms. AI algorithms, whether they be imaging algorithms, whether they be deep learning algorithms, or what have you. But somehow, as a community, we give special treatment to AI. And what I would sort of challenge the audience to is that I think it's an opportunity to look at everything that we're doing in terms of being stemmed from clinical trial-derived equations or whatnot, and ask the question, were they representative of the people on whom we're applying their conclusions? And I'd not be surprised if like 80% of the time the answer to that is no.
So I want to, I know we have a bunch of questions and I want to get to them, but I want to build on this point around, strategies that have at least made their way into the news, tackling the bias question. So the point, the algorithm you just brought up, the new AHA algorithm, around cardiovascular risk, NIGM. One of the headlines when this was promulgated was the fact that they're no longer considering race as a covariate, in their model. And I'm wondering if all three of you or whoever wants to answer the question can just comment on, does that fix the problem? Because that is a common strategy that's been employed across a lot of predictive models with that we use in clinical medicine. I just want to get a sense of how likely that is to work.
Very unlikely in my view.
Well,
Can I jump in?
Yeah, go ahead. Yeah, go ahead.
After you, Nick, if you finish your thought about why not, then I'll jump in.
I mean, if you have multiple variables, hundreds and thousands, there's probably a surrogate that the learning algorithm will pick up. That's sort of the common answer. But the other deeper question to raise is the way race is thought about in this country of 300 million people is quite different from the way race is thought about in the rest of the planet, which is another 7.8 billion people. And in many places, it is used as a proxy to answer the question, where are you from? And the question, where are you from, does have a lot of implications into the environmental exposures and the gene pool that you might have inherited. There are certain geographies where you're at higher risk for sickle cell disease. There are certain geographies where you're higher risk of G6PD deficiencies, and so on. And so just blanket throwing race out could do more harm than good. And so it's both sides. Like, just throwing it out is not going to fix the problem, because it's probably going to be a surrogate for the thing you're trying to remove. And we're kind of throwing the baby out with the bathwater here, in the sense that there is some valuable information about environmental exposures and genetic inheritance that is valuable in treating patients.
Glenn, you jump in.
Yeah. 3 quick points. First, on that last one, it's useful to disentangle what race means for social determinants of health from what it means for genetic conceptions. And the question, and Dorothy Roberts has some great work among other people on this. Okay. Second quick point, and this I think underlines something Nigam said, which is to say, people often complain AI is inaccurate, AI is hard to understand, AI is biased on racial dimensions. And my answer often is, so is your physician. All 3 of these things are true about most physicians as well. And so the question really is, are we doing better or worse? And how do we kind of make progress in this direction? Third, and again, this is a theme for me, it's worse than you think it is. And here's why. I want to underline one of the examples Rangita gave, which was this paper by Obermeyer and Mulnathan and others regarding a readmission algorithm, right, that proxied for cost as a proxy for the health state of patients and direct resources. And why I want to focus on this one is we have huge problems with what I consider to be the easy bias problem. The easy bias problem is our data sets are not very diverse and not very good. That's a very hard problem to solve, but an easy problem to conceptualize and to spot. The kind of problems of this example of the readmission algorithm are much more subtle, because ex ante, if you ask someone to design something to think about what a good continuous variable for healthcare need is, actually healthcare cost seems like ex ante kind of reasonable, and it's not a terrible thing to choose. It's only when you see what happens when you make that first choice in terms of the performance of the algorithm, really focus on it, that you understand how this label bias creates a problem. And if that's a problem for this one, think about the huge numbers of other cases where similar problems are going to persist. And that's just a much harder problem to spot and to conceptualize. We really need to train people to think, Why are you designing this way? What is it you're seeking to achieve? And how are you auditing? How are you validating? How are you benchmarking?
I don't get that. Do you want to add a thought here?
Yes, so one other complicating factor is not only race and gender and ethnicity, but the ways in which we still have a colonial mindset when we design these models. And the decolonizing of our mindsets in introducing these models is so important, Ravi. So, for example, I've been looking at the ways in which, Glenn, you talked about Dorothy Roberts, who's obviously a colleague and, someone I look up to. And I've been writing about the ways in which obstetric violence is a human rights concern and is now one of the newest categories of violence against women, that is structural violence, that constitutes structural violence. And in fact, everything that we've been talking about here is part of that structural systemic violence, systemic biases, as against interpersonal biases or interpersonal violence. And looking at the ways in which telemedicine can impact those forms of structural violence, because the way in which telemedicine is introduced without really understanding the context or the society or the community in which it is introduced. So, for example, telemedicine looking at reproductive health without really understanding the ways in which traditional societies, the men, the fathers, the patriarchy in the traditional societies might respond to the women who are undergoing those tests might cause danger and fear in that community that has deleterious consequences on women and girls. So I think it is important that we understand the traditional societies and the context that Nigam spoke of, that it is not only race and gender, but it has to be nuanced, socioeconomic, and the context of the traditional patriarchal societies that are pervasive in many parts of the global south.
That's fantastic. Yeah, and I think maybe if we could, there's been a sort of explosion of comments on the chat, and I want to try to tackle three themes that have come up. Some are around liability and who's responsible for when things go wrong. Others are around informed consent and disclosure, and then third is around how how the U.S. regulatory approach differs from other countries, and whether there ought to be a dedicated regulatory pathway for AI as opposed to retrofitting it into some of the frameworks that Nigam mentioned in his first answer. So we're going to try to tackle all three of those before we go to our concluding remarks. And if we get done sooner, then we'll answer more questions. So maybe can we think about liability, which is, of course, very salient in a lot of clinicians' minds. So maybe just if we could try to answer the questions: who is liable when AI contributes to or makes an error, and does it matter what error the AI makes? I guess so. Current state, and then how audit ought to be. Given that AI is different than other types of technologies. So Glenn, I'm looking at you first.
Yeah, although you've also written on this, Robbie, so I may look back at you, but I'll start by saying, here's the current state. So the first thing physicians should know is there's actually extremely few reported cases about liability for medical AI. Now, maybe they're all settling, or maybe there's some reason for that, but actually I think most people probably are too worried about liability. And for a lawyer to say that, that's really something, right, about this. But essentially, the rule is if you follow the standard of care, even if it turns out there's an adverse event, in theory, you should not be liable for medical malpractice. Part of the problem, though, is that AI is particularly useful in cases where it's telling you to do something non-standard. This is a patient who the AI predicts needs a different dosage or a different approach, right? So there's a way in which you might worry that liability concerns are causing you to disregard the AI in precisely the cases where it's adding value, and to follow it only when it's confirming what you would actually do. So I think if anything, there may be a concern that actually part of the reason why AI recommendations don't get followed is concerns about this. How does that change? Well, it changes over time as AI becomes part of the standard of care. And there's tons of things physicians do now, like reading an EKG. At one point, they would have done it manually. That now, if you tried to do that, people would think you were crazy and probably also liable and not the standard of care, right? So slowly, as physician groups and practice styles change, and as organizations make announcements and adopt policies, so does the standard of care. I will say overall, I think physicians are in a particularly bad position to be evaluating the quality of the AI they are using and to make individualized decisions. And my own view would be the ideal state would be something more like enterprise liability for hospitals as purchasers of AI. So the idea would be we'd have a set of rules about what is quality, and we'd expect hospital systems to be making determinations and really kicking the tires. And we'd have liability flow to the hospital systems if they failed to do so, or to the developers if they held stuff back. So that's kind of my idealized picture. Whether we'll get there is another matter.
I'm wondering, Nigam, as someone who deploys these in a health system, and how are you messaging these algorithms, whether they're for clinical decision support or actually, perhaps more than that? How are you messaging these to end user clinicians, and how do you also address concerns around what happens when the algorithm gets it wrong?
Yeah, so the ones that we are deploying, the ones we build and deploy, are not making treatment recommendations. They're essentially risk stratification algorithms. They take a set of humans and sort them by the risk of having some condition or the risk of having that some condition in the future. So in some sense, risk stratification, because you're not providing treatment recommendation, is a little bit safer from the legal standpoint, because the action still resides with the physician and whose license is on the line for whatever treatment choice they choose to make. A lot of the other commercially procured algorithms that we run in our health system, usually in the imaging space, very roughly speaking, are about speeding up the radiologist. And so they're not doing anything net new. If you're contouring, you were going to contour manually. Now the algorithm is doing the contouring for you, and you kind of adjust the edges later on. As far as I know, we do not have any treatment guidance algorithms in routine production use. I bet there's a bunch of clinical trials on things that are running, but those are under control settings under an IRB protocol. So I think the fears about liability are like grossly overstated for two reasons. One is that there's the standard of care that applies. Second, it's really hard to prove that the AI was at fault. That's another whole conversation. If you're the lawyer trying to establish that this is the algorithm's error and that is materially relevant in causing the bad outcome, like, good luck. It's really hard to prove that. But third, and the most important, AI is just not simply that widely used right now. I mean, it's talked about, but it's not actually being used.
Those are excellent points. I'm wondering, Rangi, that you can take this whichever direction you'd like to, but maybe talking about liability, or maybe to use a different word, accountability.
Yes.
For ensuring equity and bias in our algorithms. Not to say that anyone can get sued, but who are the right people to be tasking with some of the recommendations that you've stated?
Ravi, you're a soothsayer. You were prescient because you read my mind. I was going to say, Glenn spoke about liability. I am going to speak about accountability. As you may know, Ravi, I serve on a UN treaty body on the Convention on the Elimination of Discrimination Against Women, and the human rights framework calls for accountability. I am going to, in this context, speak to accountability in terms of the guiding principles on business and human rights, Draghi principles, which were developed at your alma mater, the Kennedy School of Government, by John Draghi, which calls for due diligence on the part of businesses, so that even when businesses are not directly responsible for the harm caused, that businesses are under the due diligence principles responsible for inaction, for not taking action. And therefore, would be called upon under the accountability principles of human rights. So here, once again, businesses are called first and foremost to do no harm. That is first and foremost their first principles, foundational principles, and then do good, because of the ways in which they have more reach, more resources, more influence, and more power than many states around the world. So many of the business, when you look at some of the 50 top economies, the top 25 economies are businesses, according to the World Bank. So it is important that these businesses are held responsible, are held accountable to women's human rights, to minority rights, to children's rights, because at the end of the day, we are yet to speak about the harmful implications of artificial intelligence on children, on minors, as well as minorities. So it is important to address this through that accountability principle. And then lastly, to look at, how do we integrate the revolution, the AI revolution, to the human rights framework. The human rights framework, the global human rights framework, is still playing catch up on this. And on the treaty body, on the Convention on the Elimination of Discrimination Against Women, I do ask questions to hold the state parties that are reporting before the treaty body questions on what states, what governments are doing to hold businesses responsible and accountable under both the guiding principles on business and human rights, but also under the other treaties, including the Convention on the Elimination of Discrimination Against Women. So this is still at its very embryonic level, but it is important to have these critical global conversations, Ravi, that you have convened to be able to bolster and amplify that critique on the accountability of businesses as well as states, because even states are held accountable under due diligence. And then finally, you are probably aware of the bill that was passed, promulgated by the British Parliament, that calls for a duty of care. Duty of care, which calls for anticipating the harm that could follow the introduction of artificial intelligence models. So, it calls for a higher level of even anticipating that you will be held to a duty of care for not even direct harm, but anticipated harm. So those are very important, I think, imaginative ways in which we can use law and human rights in that accountability matrix.
I think that last point that you made about thinking about the sort of cascade that may happen with an artificial intelligence decision is a good jumping off point to talking a little bit about disclosure and informed consent. So, when I send my patient for a referral for a germline test, a genetic test, to examine for heritable causes of cancer, the reason why that is not a very straightforward, I can just swab the inside of their cheek, is because of the implications of what happens once that test results and what that means, not only for that patient's treatment, but for their family members. And so that's why there's some dedicated informed consent and disclosure that is standard to happen with a test like that. So maybe starting from Nigam and then working all the way around, talk me through how you think about disclosure, not only that an AI algorithm is being applied to a patient, but that someone's decision may or may not have been influenced by something that otherwise, that decision wouldn't have been made.
No, it's a great question. I have sort of two bimodal thoughts on this. It'll come across as quite schizophrenic in the end. So the first is, if you look at any healthcare system, we probably use, a million SKUs of some sort or other in terms of, going from test tubes to reagents to MRI machines and everything in between. And we don't really disclose the use of any of them. Informed consent doesn't tell you the mechanics of how the MRI machine works. It just tells you you're going to go in and a picture is going to come out that might help us diagnose XYZ. So I would tend to think of AI not as a category, but partition it based on what is it that it is doing and use that to guide whether or not informed consent is even invoked for that. Because when you enter a health system, you already sign off your consent to get treated. I mean, at that point, you don't get a separate consent to draw blood or a separate consent to do something else. I mean, you verbally say, I'm going to draw blood, and that's it. The other thing I would say is that we have a patient family advisory council. And whenever we do something that does not fit any of the existing paradigms, so for example, using GPT-4 to respond to my health messages, it's never been done before. You know, human used to respond. Now we're kind of using computer to produce a draft. Some could say it's just fancy autocomplete, but still it's going to produce a paragraph instead of just the next word. And we would take that situation to the Patient Family Advisory Council and say, this is what we're thinking of doing. And what do you feel? What do you recommend? And that group is comprised of a very diverse set of individuals sampled from our own patient population. And we use that to guide whether disclosure is needed, or just a verbal, hey, we're using this, or maybe watermarking, or having a line saying auto-generated, reviewed and edited by your physician, or something of that nature.
So Glenn, kind of curious to get your reaction to that answer. And Nigam has illustrated a really exemplary framework, I think, of taking algorithms that ought to be deployed to Patient and Family Advisory Council to have feedback that might lead to that type of disclaimer that your GPT-4 might hallucinate when it's responding to you. Ought to be in the health system's hands, or should we be thinking about a higher level regulatory framework to make sure it happens across the board?
Yeah, so here's what I would say is that we go back to brass tacks and we ask ourselves, why do we have informed consent? Why do we have disclosure? It's part of a social practice about building trust and the idea that I'm coming to you as a vulnerable person and I'm putting myself in your hands and I'm asking you to essentially take care of me and inspire trust in what you're doing. And to me, that underlying principles which should guide us in making decisions about when to disclose and what needs to be disclosed. So I often give these two polar examples of AI. The first is the substitute surgeon. If a different doctor scrubs in to do my surgery, that is 100% the law says the kind of thing that we need to have disclosed. On the flip side, Ravi, the last time you saw a patient, I doubt you said that part of the reason why you came to the recommendation you did was dim memories of medical school lectures, experiences you had in residency, the last 7 patients you saw this person reminded you of, and maybe how your morning went, right? That kind of black box up here is not the kind of thing we feel like should be disclosed. So the question is, what is the role of AI in a particular interaction? The more it starts looking like the substitute surgeon, making recommendations, especially recommendations that we don't have a good epistemic basis for believing are good or helpful or understanding, the more I think it's our obligation, just as persons and respecting persons, to be very disclosive about that and to be quite in-depth about it. The more it's starting to just be another input and care among 700 other ones that we don't disclose, then I think the less there's going to be an obligation. We should always ask ourselves, if the patients were to find out that I didn't tell them this, how would they feel? That's a great litmus test. I'll say one more thing and then I'll subside, which is to say, I agree with Nigam in the sense that I think informed consent is a terrible way of, if you're thinking it's going to protect people and people are really going to understand and they're going to ask the questions and that's why we're doing it, turns out it really doesn't work that way. It's a technology of kind of trust building, and I much prefer technologies of trust building that focus on governance, that allow when a new thing gets introduced to the hospital, going to a community group, going to a group of patients and asking them, what would you be worried about if you had time to think about this and to learn about this? Then putting it on the shoulders of individual patients. It's just so much to ask from individual patients, and I don't think it produces much.
Rangita, I see you want to react to that.
Yes, so I'm very suspicious of informed consent, Ravi. Please forgive me. But I see this, and we often don't, because we are not only in the global north, but in very idealized spaces like Harvard and Penn, but informed consent most often takes place in the realm of power and control, especially when it concerns women and women's bodies. And power is at its peak in the healthcare system, when women are are connecting with the healthcare system, with their doctors. We see this power relationship that is very unequal, and one that creates a situation where informed consent is almost always impossible. What is considered informed consent, and we see that in forced sterilization cases, that when a woman is asked to sign a form, there is the question of, did she understand the language? Did she understand the nuances? Did she understand the medical terminology? Did she even, how did she operate in providing that informed consent? So I'm very skeptical about what constitutes informed consent. As Glenn said, we need to bring a communitarian ethos. We need to bring a critical information theory, a critical gender theory, and a critical race theory to address what constitutes informed consent. And I would like us to resort to, Paul Farmer's own way of working with the community, which really debunks the idea and debunks those hierarchical models that really allows for consent. Because informed, even the term informed, has connotations of power and hierarchy about it. What we consider informed is not what you would consider of a woman in Afghanistan or in South Sudan who is in the realm of conflict, who is, experiencing different forms of power and control and conflict to be able to address those nuanced structural challenges.
Thank you very much. I think we are probably at time for our closing statements. So I'm wondering, each of you, if we could just go around quickly for a minute each, just talk through emerging policy issues related to AI that we may not have discussed, or anything else you want to talk about. So Nigam, do you want to go first?
I think the main thing we need is a nationwide strategy to evaluate AI and assure that it's meeting some minimum bar. Right now, there's so much noise in terms of how to do bias control, how to do training and validation. There's this notion of external validation that medicine is kind of attached with, which I've argued in publication that it's kind of outdated when you're making readmissions predictions. What is the logical basis for having external validity at another site? And so we need a place where we can all go and test things on a large, diverse set of patient populations, as opposed to just a one site or a few small cohorts. So that would be my closing thing. We need a nationwide network of what we've called assurance labs as part of the work on the Coalition for Health AI.
Glenn?
We didn't really get to talk very much about generative AI or ChatGPT, but I just want to say, on the one hand, there's a real hope that maybe it'll empower patients to kind of practice the kinds of questions they might ask a physician. But I'm terrified about the mischief you can create and the ease with which one can create medical deepfakes, medical disinformation, and also possibly faking records and stuff like that. So I do really think this question of veracity of actual medical documents is something that we should keep an eye on.
Thanks. Rangita, you want to close it out?
Yes, I want to take what Nigam said and make it supranational, transnational. The UN General Assembly has acknowledged just last year that women are particularly affected by violations of rights to privacy in the digital age and the AI revolution, and has called upon all states to develop preventative measures and remedies. These are non-binding, but it is important to have that kind of transnational and supranational focus on the ways in which we address AI. And then finally, extraterritoriality. This is important for human rights obligations to understand that states are largely defined by territorial sovereignty and territorial jurisdiction, but in the case of technology and AI, we have to be able to pierce that territoriality, that sovereignty, to understand the extraterritoriality and the responsibility of extraterritoriality in companies such as, OpenAI, Microsoft, to understand that it has global reach and global power to do great good and to do great harm. Thank you.
Thank you very much. Thanks everyone for joining, and thanks to all our panelists. And I'll pass it back to Dr. Warner.
Thank you, Ravi. Thank you for all the panelists also. I just wanted to thank the audience also for participating. It's been a really wonderful conversation, and I'm glad the panelists and Ravi as a moderator could join us for an hour today. For those who are interested in our next event on March 1st, we will be doing our next virtual seminar, which will be on hospice care, entitled Hospice Payment, What's Broken, What Works, and What's Next. So please join us then. Until then, thanks to everyone and have a great holiday weekend.